Hello, and welcome to this Persiska mini tumor board on breast cancer. My name is Dr. Reshma Matani. I'm a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I co-lead our breast cancer program. It's my pleasure today to be joined by several well-renowned experts in breast cancer, who I'll now ask to introduce themselves. I'll start with Dr. Shah.
Hello, I'm Chirag Shah. I serve as the Director of Breast Radiation Oncology at the Cleveland Clinic.
Hi, I'm Stephen Poplack. I'm a breast radiologist, professor of radiology at Stanford University.
Hi, I'm Monica Morrow. I'm the Chief of Breast Surgery at Memorial Sloan Kettering Cancer Center.
Hi there, I'm Dr. Sarah Hurvitz, Professor of Medicine at the David Geffen School of Medicine at UCLA, where I'm a medical oncologist specializing in breast cancer.
This is a 39-year-old Caucasian female with a history of Hodgkin's lymphoma, diagnosed with an invasive ductal carcinoma, grade 2, hormone receptor positive, HER2 negative, currently at 13 weeks gestation, now status post-right mastectomy, and sentinel lymph node biopsy. The question that was posed to us after planned adjuvant chemotherapy with docetaxel and cyclophosphamide and delivery of the baby, would a right axillary lymph node dissection and post-mastectomy radiation be recommended? So again, just to review the patient presentation, this patient presented with a palpable right breast mass and nipple retraction during the first trimester of pregnancy at 13 weeks at an OB visit. She has a good performance status. Her pertinent prior history is important in that she had Hodgkin's lymphoma diagnosed in 1999 and treated with chemotherapy and mantle radiation. Her GYN history is shown here, and she had no use of oral contraceptives, hormone replacement therapy. Social history is non-contributory, and family history is notable in that her mom had breast cancer, so did a maternal aunt and a maternal grandmother, colon cancer in her paternal grandmother. In terms of the imaging, a bilateral mammogram did show an area of architectural distortion in all 4 quadrants of the right breast, with no abnormal right axillary adenopathy appreciated. An ultrasound confirmed the mass at 11 to 12 o'clock, and a biopsy via ultrasound revealed invasive ductal carcinoma, grade 2, hormone receptor positive, HER2 negative. A non-contrast breast MRI was considered non-diagnostic. So before we get too much further into the management of the case, let's first pause to have Dr. Poplack take us through these criteria for the safety of various breast imaging modalities in pregnancy, followed by a review of the imaging.
Thank you, Dr. Matani. I just wanted to make people aware, if you aren't already, of the ACR appropriateness criteria. The American College of Radiology has set down appropriate imaging criteria for a whole list of scenarios. This one covers breast imaging of the pregnant and lactating patient, and this is variant 7, local regional staging of newly diagnosed breast cancer during pregnancy, initial staging imaging. So I just wanted to review this because the providers chose to do a non-contrast breast MRI. I wanted to point out that mammography is appropriate even during pregnancy. We'll talk about that a little bit later. Ultrasound of the axilla is also appropriate. Whole breast ultrasound is somewhat controversial. It's listed as usually not appropriate, and that's because there is really insufficient data reported to make decisions. We could go to the next slide. So just a word for the rationale for imaging recommendations, and I've listed the URL there for providers and patients alike. Contrast-enhanced breast MRI is contraindicated. IV gadolinium chelates freely cross the placenta into the fetal circulation, and there's potential for dissociation of the gadolinium compound into a free toxic gadolinium ion, which has an unclear teratogenic effect on the fetus. So intravenous gadolinium is contraindicated during pregnancy. As we clinicians all know, non-contrast breast MRI is not appropriate because cancer is detected due to its contrast enhancement. So it's not surprising that in this case, the non-contrast MRI was non-diagnostic. Again, a word about mammography. It is not contraindicated. The fetal dose from a 4-view mammogram is less than 0.03 milligray, and no teratogenic effects have been proven under a threshold of 50 milligray. Can I have the next slide, please? So this is a representative ultrasound image from our patient, a transverse image from 12 o'clock in the right breast. And so that's the upper central right breast. And we see the darker irregular hypoechoic mass with spiculated margins. Those are those little dark extensions from the mass. And you can see there's less sound behind the mass because the tumor is absorbing sound. So we call that acoustic shadowing. Next slide, please. And this is a diagnostic post-marker view mammogram, which is really not used for diagnostic purposes, but just to identify the location of the marker clip. You can see that bright metallic clip in the upper central right breast. Not a lot of information to be gleaned from this mammogram. There is possibly an area of architectural distortion in the uppermost part of the ML view, that image to the right, the medial lateral view. But other than that, it's hard to see the malignancy on this image. Thank you.
Thank you for going through that with us. And now turning to the pathology, in August of 2021, she undergoes a right total mastectomy and right sentinel lymph node biopsy that shows a very large area of involvement, 8.5 centimeters of invasive ductal carcinoma, again with the same prognostic markers. She's found to have 2 out of 5 lymph nodes positive, 2 with macrometastases and 1 with, or 2 with also with isolated tumor cells. And she's recovering well. The plan for adjuvant treatment is docetaxel and cyclophosphamide, and her estimated delivery date of what we hope is a healthy baby is in January of 2022. So these are the questions that we were posed in terms of, after planned adjuvant chemotherapy, would a right axillary lymph node dissection and post-mastectomy radiation be recommended? And then with regards to the choice of adjuvant chemotherapy, anthracyclines versus non-anthracycline based therapy, and also with regards to the timing. So at this point, if I understand correctly the case, she's in the 2nd trimester. She's found to have lymph node involvement at the time of her surgery, which was radiographically occult, although we didn't see whether there was an ultrasound of the right axilla. But let's first turn to the local therapy discussion in terms of the management of the axilla, and I'll ask Dr. Morrow if you could please comment in that regard.
Sure, thank you. Well, first of all, before I even thought about doing any surgery in this patient, I'd obtained genetic testing. She's 39 years old. She has a very substantial family history of breast cancer in a mother, a maternal aunt, and her maternal grandmother. We don't know their ages. We don't know how many unaffected relatives, but she unequivocally meets criteria for genetic testing. And if she were to have a mutation in BRCA1 or BRCA2, over the next 20 years, she has a risk of between 25 and 40% of developing a contralateral breast cancer. And so you'd like to know that before you went back to the operating room. Moving on to the specific question of axillary dissection, this is a patient who has a T3 cancer with 2 lymph node macrometastases. So she clearly meets criteria for post-mastectomy radiotherapy. And what we like to do is avoid the combination of radiotherapy and axillary dissection because that's associated with a high risk of lymphedema. And so when it's clear someone needs post-mastectomy radiotherapy, we often will not dissect the axilla based on data from, for example, the AMAROS trial, which showed that in patients with sentinel lymph node metastases, that radiotherapy to the node basin was as effective as surgery in maintaining local control and disease-free survival, but had a lower risk of lymphedema. Now, the only thing that makes this decision a little bit more complex is that this patient has already received mantle irradiation. And so I would talk to my radiation oncology colleague to find out if that was going to pose a problem for node field irradiation. And if it did, then the default position most certainly would be an axillary dissection, because there's a significant risk of a heavy tumor burden left behind in the axilla. And this is not a patient who would have been included in the available trials of no axillary dissection, no radiotherapy, where the vast majority didn't have mastectomy and none of them had T3 tumors.
Great segue to our next question for Dr. Shah in terms of the recommendations regarding post-mastectomy radiation in this patient who had mantle radiation in the past. And also, I'll just ask you to comment on what you would quote a patient's risk of lymphedema in the setting of having received post-mastectomy radiation as well as a lymph node dissection.
Yeah, thank you, Dr. Matani. And I agree with Dr. Maros. I think this is a common question we get asked, is if the patient has received radiation, even mantle radiation, can they have radiation again? And my answer is they can equivocally have radiation again. We've retreated many patients in this situation. It's often almost impossible to get previous radiation records in these situations, given the duration of time. That being said, mantle fields are pretty well known in how they're designed. And so we usually don't need the fields, we just need the dose. And usually the dose in a case like this in someone who was treated in that generation is somewhere between 30 and 45 gray. And so we do believe that we can retreat. The biggest side effects we worry about in retreating patients who have had Hodgkin's mantle field radiation are a couple. One is cardiopulmonary toxicity, given that the mantle was usually delivered with either 2D or early 3D techniques without cardiopulmonary sparing, as well as potential brachial plexopathy, given that you may be giving a combination of almost 85 to 90 gray. That being said, there's good data on the reirradiation of the plexus saying that your risk of plexopathy is under 5 to 10% when you go below 95 gray cumulative to the plexus. So I do think you can give radiation again. In terms of radiation, I would offer post-mastectomy radiation to the chest wall, to the lymph nodes, including the internal mammaries, the supraclavicular nodes, and the undissected axilla as well. In terms of dose, given the previous radiation, I would probably give 45 gray to the supraclav to kind of minimize the reirradiation of the plexus, 50 gray to the chest wall and the other lymph nodes. In terms of lymphedema risk, obviously AMAROS gave us some data. The question is whether reirradiation of parts of the axilla increases that risk, and I think that's a not very well answered question. The data that is available would probably quote at least a 30% risk of lymphedema when you give radiation twice to the axilla. There are factors that obviously impact that, including how much dose to what areas were given, but that's what I would quote.
Thank you. I guess now we should turn to the systemic therapy decision in terms of the choice of chemotherapy in the situation. Dr. Hurvitz, I'm curious as to your thoughts on the use of anthracyclines versus non-anthracycline based regimens in pregnant patients with breast cancer, and also if you could comment on the timing and the safety of receiving the chemo.
All right, so this case presents a number of issues to address from a systemic standpoint. I first want to echo what Dr. Morrow said earlier regarding the need for genetic testing. It would be easy to assume that this cancer stemmed from her prior mantle field radiation, but her family history and her age are very compelling reasons for germline genetic testing. And it's not just from a surgical standpoint, but also we now have the approval of olaparib, a PARP inhibitor, for use in BRCA mutations, high-risk breast cancer, and a germline BRCA mutation in the adjuvant setting. And I would want to be able to take advantage of that therapy after chemo if she was in a patient who carries the germline BRCA mutation with a cancer like this. In terms of systemic chemotherapy in a patient who is pregnant, most of the data supports the use of anthracycline-based therapy, given the number of trials that have supported their safety in this setting. However, this patient most likely already received anthracycline-based therapy for the Hodgkin's lymphoma, and there is a lifetime limit of which a patient can receive of anthracycline. So one would have to look back at the records and see how much she had received previously for the Hodgkin's lymphoma. Outside patient who had Hodgkin's lymphoma, I will often utilize AC chemo during the pregnancy and preserve the taxanes for after delivery. There is some data suggesting that taxanes may safely be done in the third trimester rather than the second trimester. And then there's a greater issue of whether or not anthracyclines are really going to benefit a patient with this disease, putting the pregnancy issue aside. We just published yesterday in MPJ Breast a very long, very detailed review of the use of anthracyclines in curable breast cancer. And when you take into consideration all of the clinical trials in the taxane era, looking at how much anthracyclines benefit a patient, it really does appear that they benefit patients primarily who have a heavy disease burden. Now, some would argue this T3 tumor with 2 nodes involved qualifies as a heavy disease burden, but really the studies indicate 4 or more lymph nodes is the threshold where anthracyclines benefit someone. So I would be in favor of using a non-anthracycline-based regimen in this person who has previously received an anthracycline and use the taxane after delivery, since she's already had surgery. Finally, she needs staging. If that hasn't been done, I may have missed that. And my last point is we may soon have the availability of Abemaciclib, a CDK4/6 inhibitor for high-risk hormone receptor positive breast cancer. This patient would have qualified for the Monarch E clinical trial, and that is something that we might have FDA approved in the coming months. We'll have to see. And of course, endocrine therapy will be a very important component of her treatment.
Thank you all for the thoughtful discussion surrounding this case.